do something else, but it's gonna have to go through all these, right? So H. pylori infection. And then what about NSAIDs? Yeah, we know that NSAIDs can cause GI bleeding. Corticosteroids too, that's why you have to take it with food. Potassium chloride, like tablet pills. Increased stress. How about nursing school? Yes. Oh yes, you could get, I had gastritis through nursing school. Radiation therapy, ooh, can that cause ulcerations? It could also cause ulcerative colitis. Chemotherapy and malignancy. But the thing in red on this card for risk factors are H. pylori infection. So that is a highly tested thing. Signs and symptoms, you can get some epigastric pain, nausea, vomiting, bloating, hematoemesis. What is hematoemesis? Blood, yep, throwing up blood. Isn't that a good assessment gift? When they come to the ED and the red blood, and you see it from a distance, frank red blood, beautiful. It's like, oh, they have an upper GI bleed, it's great. So we're gonna be running a CBC with DIP, probably gonna be giving blood. They're probably hypovolemic or at least dehydrated. We're gonna start some saline. Yep. Now this is also some signs and symptoms in red. This is what it says. For a gastric ulcer, you're gonna have pain 15 to 30 minutes after a meal. This goes way back to nursing 305. So pain 15 to 30 minutes after, so that's pretty quick, right? It's like, ugh, what is going on here? Worse during the day, probably hormonal, I'll bet you. And then worse with eating. That makes sense, doesn't it? And the reason is because when you eat what happens in your stomach environment, what goes up? The release of hydrochloric acid, right? And when you have more acid, is it gonna cause pain? Yes. And then duodenal, and where's a duodenum or duodenum? Yeah, right there. That little pouch right after the stomach, typically responsible for dumping syndrome. That's where it goes, right? And so this is pain 2 to 3 hours. So that makes sense, doesn't it? So it's in your duodenum. It's going to be 2 to 3 hours after a meal. Worse at night. Different, right? So it's probably because of the position. And better with eating. Do you guys remember any of this stuff? Oh, good.
This one I do because my mom had duodenal cancer.
Oh, yeah. So the symptoms are similar?
Yeah.
Yeah. Unfortunately, it's a bad way to learn it. But so the way you would do that, so one is longer because of the exposure, right? And then one's worse with eating, one's better with eating. The duodenal better. So that's what I have on this one. The second one is going to be, treatments. So what is the cause, the number one in red cause of PUD, H. pylori infection? So what are you going to treat them with?
Antibiotics.
Antibiotics. And you guys already know that, but in a different context, you know. So it's going to be, what it says here is multiple antibiotics, because you have multiple GI bugs. And then, let's go down to the red down here. Perforation, we've already talked about that. That's what I worry about. Because what can perforation lead to? Death, secondary to sepsis, and actually hypovolemic shock, ultimately. Both of those, sepsis, SIRS, all that. But this is what's in red, rigid. So when you feel the abdomen, it's going to be rigid, and it's going to be board-like. So it's very hard. It's almost like there is a basketball in there. So rigid and board-like. And by the way, this is not describing PUD. This is specifically describing perforation / peritonitis right here. You see where I'm going? So actually, could you conceptually take this across the board, the peritonitis and perforation? Yep, across the board. So whatever type of thing that causes the peritonitis, like the perforation or in the peritonitis, that's what you're gonna assess. So that'll cover everything, peritonitis, in terms of the most important thing you need to know. Okay, let's just keep this going. Let's go off to, how about some cholecystitis? Okay, who remembers what cholecystitis is? Gallbladder. So inflammation, you have the itis there, right? So patho, it can be caused by gallstones. And what's that called? Lithiasis. Very good. Lith is like stone. That's how we would remember that, right? Gallstone blocks a cystic duct or common bile duct with CBD, obstructing bile flow. So everything backs up, right? The bile, and that's what causes the inflammatory process. This causes chemical irritation, inflammation of the gallbladder, decreasing flow, and guess what happens if that is left untreated? Cholecystitis. Necrosis of the gallbladder. Is that bad? Anything necrotic in your body could kill you. So yeah, so that's the cause. How about some red you would like to write down? Related factors, we've already talked about polylithiasis, right? And can anybody come up with the other red item here for cause or risk factor? You guys remember? And this is definitely a matchy. Yes. What diet? Yeah, high fat. So the evidence that we know is when they eat a high fat meal, they get the pain, right up the quadrant pain. And that's like, oh, that looks like a duck, squawks like a duck, must be a duck. And nausea and vomiting. Oh yeah. I remember Ruthie at the hospital had cholecystitis. She eventually had a cholecystectomy. And females are higher at risk, obesity, age, and genetics. Huh? Oh, did you really? That was horrible, right?
I know. My parents have just gotten theirs like a year prior to it.
So very genetic in your end of the course there. Yeah. So every time you ate, yeah.
It's like right underneath the ribs.
You can't get comfortable, right? Is it constant? Yes. So I'm glad you're bringing up the pain thing, because if you work the ED, there's this broad diagnosis of acute abdominal pain. So what all falls under that larger category? Would you agree, cholecystitis? What else can cause acute abdominal pain? Appendicitis for sure. Pancreatitis, definitely for sure. That's a worse pain. What else? Peritonitis, yes. How about gastritis? How about diverticulitis? All of that. So yeah. So in this particular case, then you start getting your differential diagnosis as to where the pain is. So we know that they come in like this. Oftentimes they're throwing up. That could be a number, like peritonitis. Pancreatitis is a throwing up thing. Cholecystitis is, gastritis is. So it could be any of those. But where did you have your pain? You said under the.
It was like right underneath.
Yep. Very pinpoint. But there's also a referral component. Yeah, up to the shoulder, and it could even end up in the under the shoulder blade, the scapula on that side. Those are really considered hallmark findings, cardinal findings for cholecystitis. And then you have the high fat food, signs and symptoms, nausea, vomiting, and you can read those. So what we have in red were related factors, or risk factors, cholecystitis, high fat diet, and the very, very hallmark finding, right upper quadrant. Good. I think there's another one for cholecystitis. Let me find it. We know what the treatment is. Oh, let me ask you this. If they do have a common bile duct blockage, what other problems can that cause? common bile duct, the gallbladder, pancreas, and this big thing right over here, liver nut, right? So, if you have a blockage from a stone that moved down, cholelithiasis, right? What other things would you expect besides pain? Would the white count go up? Yeah. What else? Jaundice. Perfect. That's one of the things. And how about elevated liver enzymes? Yeah. We're going to get to that. Let me just finish off cholecystitis. And there's IBS, hepatitis, GI procedures, Crohn's. See, these are all the things you have to review before CMS. These are the ones that are mostly missed on the thing. You know why? It's not because you have teachers who can't teach it. Are you kidding? She's awesome. It's so far back. How can you possibly even remember this semester's stuff in week 1? Oh my gosh, no. Liver, pancreatitis, bariatric surgery. I can probably just do it right off the top of my head. I'm just trying to come up with all the red stuff for you. So, how do you treat it? How about changing diet? How about a low-fat diet? And these are the conservative stuff, right? What are the surgical procedures? Cholecystectomy, and what 2 different types of cholecystectomies are there? Laparoscopic, and what's the other one? Open. That makes sense, right? Open always means, versus laparoscopic, open always means incision. Now with a lap chole, they make a tiny, tiny incision to get the laparoscope in there, right? So they can go and cut and do their magic. But an open chole, the incision is about this long, so it's not that bad. Same thing for appendectomy. You could do a lap appy, a lap chole, but why do they open them up sometimes? Infected, or like if you have a ruptured appendix, which we're probably gonna get to, like that other side. Yeah, so might they have to irrigate and clean things? Are you okay?
Yeah.
Are you going into labor?
Not yet.
Okay. When do you do?
You don't think?
4 weeks.
She could feasibly go into labor.
Go to Disneyland.
Are you okay?
I'm just feeling like more back, so that's what's making me a little, yeah. I know. That's what I'm thinking.
Back labor? Yeah, get her, 'cause yeah, I'd be useless.
We can use your
Yeah, we can all look at your baby. Oh, yeah. I don't know if you guys have ever done this. I worked with a tech. I knew she was gonna be going into labor, and you know how I could tell? By the look, like the harshness on her face. Does that make sense to anybody? Her face, well, she was feeling something. She was feeling tired, she was feeling just a little bit of pressure. And I looked at her face, and this is what I remember. Her face was just like hard looking. And I go, oh my God, and I know nothing about OB. I passed all my tests and everything. And I said, and I even told her this, I said, oh my God, I don't know anything, but I think you're gonna go into labor.
That's
And
exactly
guess
what they want to hear.
She went into labor like 4 o'clock that morning. She really did. Yeah, and I could just see it on her face.
That's how I look.
Do you know what I'm talking about?
I just needed to wait 2 weeks.
It was like,
I need 2 weeks.
wait, yeah. So what's it called? So you can do a lap chole or a open chole. Now, what do they do when they do, whether it's a lap appy or any laparoscopic in here? Do they pump gas in here? Why do they do that?
Expander.
So they can visualize and not mix something, right? What is the problem with that? You may have experienced this. So what do you teach them that they are going to feel from that gas? Yeah, it hurts. They get caught up and they're just like somebody pressing you like that. How do you alleviate that gas? Walk, 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 and breathe, breathe, breathe. Breathing is the key thing, ambulation and breathing, because the gas will get absorbed in the, faster. If you're just laying in bed, oh my God, that's slower, that process will be so much slower. Okay.
That shit go.
Oh, yeah, that's right, that's right. Let's go to appendicitis. I can't find my other thing, so this is surgical thing. Lap, appies, and choles, usually 3 lap sites. Open, you're gonna have 1 incision. Appendicitis. Okay, so inflammation of the appendix. This is what we have here in red. Please write this down. It's called a McBurney's point. You guys remember? Oh, I like that. Oh, you guys remember it. That's so cool. And what's a McBurney's point? Yeah, they probably taught you that first in health assessment, and then they probably reiterated that in 305. But what is, so it's right in here, it's like a triangle in a way. And there was a good picture, I think, in your health assessment book with that. But, and Fundy's too. But what's the major point about assessing if it's appendicitis? Rebound pain. Good job, you guys. You're getting this. And here we go, complications. Okay, this is in red. How do you know that a patient has rupture? Yes, oh my gosh. Very exciting, because you know these are potential CNS questions for you. And I'm just gonna hope these are on there. Sudden relief of pain may indicate rupture of the appendix. Doesn't that make sense to you? Because if you have an organ that's full of pus and white cells and fluid because it's so inflamed, that's the part that hurts. It's when that's decompression of pressure, when you burst. But then is that not good? Okay, now again, what can that go to? What can that turn to? The big P, peritonitis. Anything that ruptures from your GI tract, or from anything for that matter, into the peritoneal sterile organ, peritonitis. That's what you should be thinking. This is bad, hot. It's a hot appendix. What exactly is the appendix? What do you think it is?
End of your.
I really love this part. We're gonna go into Crohn's next. So back in the day, I had to Google it. I had to find out why we have an appendix. It looks like this. It looks almost like your uvula, but it's left over from your caveman days, caveman and cavewoman. So we were eating things that we no longer eat. That it contained enzymes in there, almost like digestion. And so when our diet changed to other things, we no longer needed it, so it shrunk down. So it's just a thing, a leftover part that we no longer have. But look how many problems it causes us. We're not perfect, right? Okay, Crohn's disease. What do you guys remember about Crohn's disease?
Stomach issues.
What is it?
Stomach issues.
Definitely stomach. And you know what I like to do? I like to think about Crohn's, UBS, or IBS, and UC. Put those in the same bucket, because are they similar clinical presentations? You guys remember? Like, and I'm gonna go through these, and then I'm gonna go to UC, ulcerative colitis, and you'll see the similarities. So we have chronic inflammation involving the entire GI tract, most common in the distal small intestine and proximal colon, and it affects all layers of the bowel wall. Characterized by periods of, and here's the thing, and I believe this is also common with UC, periods of remissions and exacerbations. So it comes and it goes. And then, how about we write this down in red? This is the patho. It consists of patchy ulcerations. Patchy ulcerations, and they're called skip lesions. And I asked the class before if they've heard of skip lesions, and they have not. Right, they had heard. So please write that down, it's on here. So this is how it's characterized with the pathophysiology, patchy ulcerations. And guess what? The other thing that it's known for in red is risk for fistulas. Oh my God, now what is a fistula? So glad we're doing this. When I was going through this, it's like, oh my God, these are just good, common. Huh? That's what somebody else said, the AV fistula. All right, so this is what a fistula is.
Fistula is, like, a breakage between the skin. I see it in between the vagina and the rectum.
Yes.
The bladder and the vagina.
Exactly, it's a tunnel. And what's typically caused by the tunnel, like she said, you typically have, like, that's a perfect example. From the rectum to the bladder or the vagina, because they're in close proximity. Usually what happens is there is an infection down there. And what happens is you have, would you agree you have waste products with infectious processes, like pus? So guess what that does, is it starts to bore a hole and a tunnel through tissue, and guess what now you have? Not only do you have this tissue, this infection in like the bowel or burring or that tunnel creation from the bowel to the bladder or the vagina. The last I heard, that's not a good thing. That is a fistula. Can you have a fistula, and this is what I worry about. Can you have fistulas that just create those tunnels out into the peritoneal cavity? Are we dealing with peritonitis again? Oh, I'm so glad we're doing this. This is just good, basic, conceptual stuff. So, and I'm gonna ask you guys, what is it characterized by? Number one, patchy ulcerations and the risk for fistulas. And we know fistulas can turn into peritonitis. That's bad. Or bad UTIs, which can turn into urosepsis. Because if you think if it's from the bowel, you have that gram-negative, can you get a gram-negative septicemia? And then there's signs and symptoms. And this is where these really, really seem very similar. Diarrhea. 5 to 6 loose stools per day is what's in red. That's too much. What are you worried about if they're stooling too much? Dehydration and potential hypovolemic shock. And then, so we'll be treating that probably. And what is steatorrhea? This is not in red, but what is steatorrhea? Fatty stools. Have you seen it? It's really weird. It almost looks like melted wax in the toilet on top of the stool. That's steatorrhea, and it's stinky. ST. Really? Does she have any abdominal pain?
Yes.
Yeah?
A
Can
lot.
you take it?
Like, she was gone to the GA doctor, I don't know how many times.
And they can't find the sculptor?
No, not yet.
When I used to work in a GI department, we used to see a lot of patients who had like internal hemorrhoids would come out with a lot of that type of stool.
Yeah,
Yeah.
that's right.
Because of like the excretion of the mucus, so you would see a lot too. of that.
Yes, that's right. When you have something pathologic in your gut, you know what your gut's gonna do protectively? It's gonna make extra mucus. So that might be what you're looking
She
at.
has like a severe dairy allergy too. So if she
Oh,
eats dairy,
yeah.
they could just,
Mucus.
yeah.
And then that is can be a problem with the liver too. So steatorrhea, there's a lot of different causes of that, root causes. Steatorrhea, right lower quadrant pain, And this is Crohn's. Weight loss, fever, and fatigue. So let's go to ulcerative colitis. These were perfectly in order before, until I messed them up. Well, there's IBS, hernia. Oh, diverticulitis, I want to do that one too. We had some fun. Well, there's peritonitis. Oh, here's UC. There's 2 cards. Okay, let's do UC. Let's see what sort of commonalities we can find out. So, what is UC? Inflammatory disease of the colon characterized by periods of remission and exacerbation. Is that the same thing as Crohn's? See the commonalities? That's why I like to put those together. But guess what? UC's worse. You know what? This is in red. And I've heard this and seen this. Continuous ulceration. Are you worried about continuous ulceration? In what way? Couple of things. Bleeding. Exactly. You know ulcerations are destruction of that lining, so you know they're going to have some bloody stools, not pretty. Now that could be colon cancer, ulcerative colitis until they do the scope and visualize stuff, right? What else are you worried about that we've already talked about? With ulcers in your colon, are you kidding me? Why is that bad? Bowel perforation. There it goes again. Can diverticulitis cause bowel perforation? Can it poke holes in your bowel? Bowel perforation, even if it's a little one. Can you have leaky stuff going into a sterile peritoneal cavity? All these are bad, you guys. So this is what it is. So those continuous ulcerations are in red. Related factors. Is this an autoimmune disorder? Do you guys remember it being autoimmune? No. It is. So please write it down. It's in red. So this. You think the Crohn's was bad? 10 to 20 liquid stools. So now you're talking about a much higher risk of hypovolemic shock. Very quick dehydration. So since they have diarrhea, how are you going to stop those stools? Is there a med that you can give that's great? And it's a controlled substance.
And help with pain.
So this drug I'm talking about is a combo, and it contains an opioid, and I'm going to tell you what it is here in a second. You may have not heard of it. It's an opioid and something else. What is something else that'll slow down motility and dry your gut out? Atropine. You guys are so smart. It's called Lomotil. Get it? Low motility. They actually get it right sometimes. So it consists of an opioid called diphenoxylate. The other class have not heard of that. Have you ever heard of Lomotil? Diphenoxylate. So that, yeah, the typical opioids, you guys know, morphine, Demerol, blah, blah, blah. So diphenoxylate is an opioid narcotic. Now, why do they add, and you're right about the opioids, so what do the opioids do to the gut? They slow down the motility. See where we're going with that? So they have a hypermodal thing in ulcerative colitis. It's like irritated all the time, like oh, with blood coming out, very painful. If you've seen it at the hospital, you know, oh, they're miserable patients. But what I've read in literature, the reason that they do the atropine is to dry them out, but guess why else? So people will not abuse the diphenoxylate. Isn't that weird? Because who wants anticholinergic effects? Nobody. Who wants a dry mouth? Who wants tachycardia? Who wants constipation? Isn't that weird? So they indicate that's why they put the atropine in there for 2 different reasons. To dry out the gut, but also so they don't abuse a drug for the diphenoxylate alone. Okay, other things, abdominal pain, absolutely. Fecal urgency, weakness, weight loss, and dehydration. And that's because they're stooling all the time. 10 to 20 per day, are you kidding? That's not a good day. Yeah, it's horrible. So you guys are gonna be replenishing with fluid, some saline, or probably even more, maybe a D5 with some KCL or something. But there's something that I also told the other class about the colon. What magic happens in the colon? Absorption of water. Did y'all know that?
Well, small intestine is more nutrients, large intestine is more water, correct?
100%. 100%. And this really reflects back to your A and P, right? If you have problems just generally with your colon, you're gonna be watching for major dehydration. All of these colon problems, that's a big worry. And then, not on top of that, you have the diarrhea with the Crohn's and the UC. Oh, this is another great, God, this is so, I'm so glad we're doing this. Will your white count go up with UC? Will it go with Crohn's? Your exacerbated states, yeah, when they show up to the hospital. Can't stop pooping, you know. I want to ask you, what is your major serum indicator that there's inflammation in the body? There's two. Do you remember that? It seems like you guys do that. That's the beginning of inflammation. What is it? Oh, that's pancreas. And you draw it. You actually even draw it for RA. CRP. C-reactive protein and erythrocyte sedimentation rate, ESR. So whenever you see that on a test, those are indications that there's an infection process. So to reverse that for a test question, if it has an itis behind it, they're probably gonna order a CRP and an ESR. And do you know that sometimes they'll order it for an MI? Absolutely, because they have found, especially recently, with MI, that the vessels have inflammation in them. Isn't that weird? Like the coronary vessel. Well, there's damage in there. The plaque. And so CRP, even in an MI, can be elevated. So try to think, put your conceptual cap on and think, itis, you're probably gonna order ESR CRP. That would be it. I hope they ask you something. Autoimmune 10 to 20, oh my God, that's horrible. And then if you guys wanna look up the medications, we give immunosuppressive, because, and then you think about the concept of autoimmunity. How do you treat general autoimmunity? Steroids, which are immunosuppressants, right? So if you think about anything that shows up like scleroderma, multiple sclerosis, glomerulonephritis, lupus, RA, UC, part of that treatment is going to be immunosuppressants, absolutely. And then, yeah, y'all can look at the other ones, yeah, monitoring isonose electrolytes, CBC levels, because they're bleeding. Avoiding, and then there's some other things too. Are we gonna make them, all these GI things, are they gonna be nothing by now? Absolutely, absolutely. Okay, so that's enough of that. Let's go to, what time do we have? What time do we get out? 45. So do we have 15 minutes? We'll just continue with GI. This tended to be a low performing level last semester, so I picked it out for you. I know it's not as fun as doing heart, but it must be done. Okay, IBS. So what is IBS?
Irritable bowel syndrome.
Oh, yeah. Ooh. This just sounds horrific. Intestinal disorder that causes abdominal pain and changes in bowel movements and the absence of other diseases. You see how those three are very similar, very similar. Patho, they don't even know why. But factors, related factors. Stress. Did somebody say stress back there? Yeah. So, could you develop this during nursing school? Yeah, you could. And then mental health disorders, intestinal bacterial overgrowth, food sensitivities can cause IBS. But here we go. Here's where the commonalities of these three disorders come in. Pain, bloating, guess what? Diarrhea. Now, there was a student who knew this, that there's a couple different types of IBS. I thought that was really brilliant. There's IBS-D, which will give them what? IBS-C is the constipation. IBS-D is the diarrhea. So that's easy. That would make it super easy. So that's right. So it indicates with IBS you can have either or, depending on the type. So what they have documented in evidence clinically is that some people have one or the other type. That makes sense, doesn't it? And clearly, do we treat them differently? Yeah. And some can have a combination. So what is what's the designator for the combination? IBS-M. So there's an M combination. Yeah. So you could have either of the three, right? Does that make sense? Okay. Improvement in symptoms upon defecation. So they feel better once they pee. Yes. Oh, thank goodness. Like we all do. Especially after being constant. Do you know that I'm getting to be such an old lady? I've never had constipation in my life until this year. Oh, I know you all the time. It's just, I'm telling you, age it's not fun. And then it'll tell you about the treatments and things. So there was nothing really big in red on that one. Have we talked about diverticulitis? Let's talk about diverticulitis. What exactly is diverticulitis? It's inflammation of the diverticula. And what are diverticula? Those are little outpouchings, right? But they're not that bad. They can be precancerous, can't they? So when you have a scope, are they looking at those for suspicious cells? And then of course, the diverticula can get filled up with what? Food.
That's why
Yeah.
when they have it, they tell you not to eat seeds or nuts or.
That's right. Or anything with cellulose.
Yeah.
Like corn, non-digestible
Yeah.
cellulose, right? Because it can get caught up in the diverticula. That's more than one diverticulum. So several diverticula. So, and then that's when it gets infected. And then that's when they get into diverticulitis. So if you've ever seen a patient with diverticulitis, what are your symptoms? What do they have? Pain, acute abdominal pain. And what kind of pain? What would you imagine the gut would give you? Crampy? And I think pressure, yeah, would be a thing. But I think the good word would be crampy pain. Because think about you when you have, yes, when you have gas in your gut and it's high and you can't like get rid of it right away, it hurts. Sometimes you'll double over, right? So it's crampy pain. The problem with diverticulitis is the pain does not go away. Now what, let me see, I'm sure they have diarrhea too. Let's just look. Undigested food and bacteria accumulating in the diverticula, leading to inflammation and infection. Related factors, low fiber diet. Because if you're on a low fiber, do things get sort of stuck in your gut? And you see all these commercials about, yeah, you have tons of garbage in your bowel. You know, so probably true. Genetics, obesity, smoking, NSAIDs, corticosteroids, and the pain, they say lower left quadrant pain. Is your white count gonna go up? Is it anything inflammatory conceptually with itis behind it? Can you expect the white count to go up? Some more raging than others, like for example with pyelonephritis, kidney infection or peritonitis, you will see raging white counts. With this, not as bad, not as bad. Are you gonna see some ESR? And they don't have CRP, but they do have ESR on this one, elevated. Okay, I want to ask you this question for diagnostics. Do you guys remember about the barium studies? What is barium? Contrast. Contrast, right? Do they swallow it? Yeah. And some of you have probably seen it. And it goes down the GI tract, and it takes a while for it to go down all the way. And then they do an x-ray, and they can see structural abnormalities, they can see all kinds of stuff, inflammation, and then you compare that with your labs, your white count, your ESR, you know, it's inflammation, right? And then the diarrhea. Oh yeah, you can have loosey-gooseys with this. And you can give a PO, can you give an enema? Remember the barium enema? Now, what does the barium look like when it comes out? Like chalk. Did someone say chalky? Yeah, that's correct. White, chalky. And then do they do a colonoscopy for diagnosis? Yep, for diverticulitis. CT scan and lower GI series, which is scopes. Stick them up. Antibiotics. Okay, what would you like to give your patient, see if you can figure this out, for pain, for any acute abdominal pain? Starts with a K. And that's a generic name. Torlac. They will thank you. They're coming in and they're hurting like there's no tomorrow. Any of these things, pancreatitis. So what we do is we get out our Ketorolac, we pull up probably a load, which is 30 milligrams, and we go IV push, and within a matter of 15 to 30 minutes, are they feeling 1,000 times better? Oh, and why? Do you have itis attached to the pathology? That's it. Will Tylenol work the same? No. So you future prescribers, are you gonna do Tylenol? Absolutely, you're gonna get that good Toradol. A lot of people think it's an opioid, it works so well. Okay, so, and they have left lower quadrant pain. So what would that, and do they give infection? Do they give antibiotics? Yep. And are you worried about peritonitis because of valve perforation? Can the diverticula burst into the peritoneum? Yep, it absolutely can. So that's scary. So do we make them nothing by mouth to rest the gut? And also, this is the other thing about diverticulitis. What if they keep coming in with bouts of diverticulitis or cholecystitis? Now what are they looking at?
Right.
Clipping a resection of the colon. That's exactly right. And so then what they do, they'll look at the scope and they'll find the diseased part of the bowel. You guys realize you have a lot of bowel. So you have a lot to spare. So what they do is they take this tube, they cut. What is it called when they sew the ends together? Anastomosis. Very good. Now, are you worried about the anastomosis site? What can happen there? Leaky leakies. Like with a Whipple. Remember the Whipple? That's a lot of cuts. Lot of cuts. That's what I'm worried about. Peritonitis. Yep. Okay, diverticulitis. Yeah, we give antibiotics, we give Toradol. Give the Toradol. Usually it works pretty well. Can you give them opioids too? Yeah, of course. Monitor their stools, monitor their thing, but if they keep coming in, they're gonna cut it out. Okay. We had IBS. I know this is not quite as exciting as cardiac, is it? But must be done. Oh, paracentesis. Bariatric surgery. Oh. Pancreatitis. We've already done, this doesn't go to 305, but let me see what you remember. And this will prove to you that the things that you've taken recently is probably in your head. So what's pancreatitis? That's exactly right. It's inflammation, right, that could easily get infected, right? And we're always watching for SIRS with that. Caused by drinking, common bile duct blockage. In red, what are two cardinal findings with pancreatitis? And they're probably names of physicians, do you remember? Cohenstein and Ray Turner's, you guys remember? I think I put that on the text. That's in red right here. Yep, alcohol abuse. There's a second card. See what's in red here. Oh, what are your labs associated with pancreatitis? Amylase and lipase. It makes it easy, doesn't it? And that's in the setting. If you're a third patient and the ED, I can figure it out in 2 seconds what it is, just by the labs alone. And then they're going like, see, where's my pancreas? Does it refer up to the left shoulder? Yeah. But it's mostly this, like from here around, is where they're gonna have the pain. And it is not fun pain at all. It's constant. So are you also gonna have not only your amylase and lipase, is your white count gonna be? See, because it's all itises, white count's gonna go up. Oh, if it is a common bile duct issue, is your bilirubin gonna go up? Yes, so if it is common bile duct blockage, bili is gonna go up. How about the glucose? Is that gonna go up too? And by the way, these are all in red. Amylase, lipase, white count, WBC's up, bilirubin, glucose. Oh, remember the calcium? Down. And remember, I told you I didn't want to go into the complete pathology, because I really didn't have time. If you're interested, look it up, but no, I'm not gonna spend time. Magnesium is also gonna be going down, and the platelets are too. That's all in red, all in red. And now, what about chronic pancreatitis? After they're eating, were they NPO during acute phases? And why were they NPO during the acute phases? Do you guys remember? Yeah, they will be relieved. If you take a sip of water, or even if you smell food, you know what your pancreas is gonna do? Oh, I'm here to digest food. It's actually working. But then that's what causes the additional auto-digestion of the pancreas and the additional pain. But after they start eating, is there something that you need to give them? And then this is for chronic pancreatitis after they go home. And yeah, the pancreatic, like lipase, amylase, that's correct. That's in red, by the way. Can you, during especially the acute phase, will you probably be giving them insulin? Because is the pancreas able to release insulin? That's the part of the problem too. Things get trapped into the pancreas. Opioid analgesics, antibiotics, antiemetics that we talked about with pancreatitis. Yeah, and pancreatic enzymes. Is it almost done? Are we done?
I have a question. Yes, ma'am. So like,